today's session of Shisu Samhita Dhyana. I would like to call upon Dr. Mohit Sharma sir, Professor Emeritus, Department of Cell Tantra, SDMC Udupi to take over the session. Welcome sir.
Okay, thank you. Now, the next is अथ प्रमेह पिडका चिकित्सा व्याख्यासाम्यः यथोवाच भगवन्तः प्रमेह पिडका चिकित्सा शराविकाद्याः नव पिडकाः प्रागुप्ताः ताः प्राणमतो अल्पाः अल्पाः त्वङ्मांसप्राप्ताः मृद्व्यः अल्परुजः क्षिप्रपाकभेदिन्यश्च साध्याः. Now Sharavikadi, now these Prameha pidakas are explained in the Nidhanasana, and we have discussed that in detail. And those Prameha pidakas which occur in a healthy, otherwise healthy person, and those which are relatively small and which are relatively superficial, limited to the subcutaneous plane, and which are soft and comparatively less painful, and which tend to have a rapid course, suppurative complications of the diabetes conditions, they are curable. Others are not curable. Prognosis is not so easy. Now, tabhi upadritam pramehanam upachareta. Now, you have to prevent these either prameha pidakas, or you have to treat them once there is a early signs as such. If there is a early signs of the prameha pidaka, they need to be treated. तत्र पूर्वरूपेषु अपतर्पणं वनस्पतिकाषायं बस्समूत्रं च उपदिशेत्. Before the prameha has occurred in the purva rupa, the patient who has a tendency to have the prameha, then in such patients apatarpana is the main line of treatment. That means the diet restriction, which we have already discussed in the previous chapter, like diet and exercises, vanaspati-kashaya, bastamutra, the urine of goats, such diet which would have lesser calorie has to be administered. एवम् अकुर्वतस्तस्य मधुराहारस्य मूत्रं स्वेदः श्लेष्मा च मधुरी भवति प्रमेहश्च अभिव्यक्तो भवति तत्र उभयतः संशोधनम् आसेवेत. If this is not followed in the prior, in those who have a diabetic tendency or who are pre-diabetic, and where the diabetes can be prevented with the diet restrictions and exercise, if these restrictions are not followed, and if the patient continues to consume excess of food and does not really do the exercise, in such conditions it results in an established this prameha, where the urine, the sweat and the phlegm in the body, it becomes totally sweetened, like, or maybe the altered, chemically altered, and it presents with the full-fledged clinical signs of the prameha. In such conditions, Ubhayata Samshodhanam Aseveta, woman and liberation is the right choice of the treatment. Now, if this is not followed, even after establishing the diabetes, and if the Shodhana is not followed in such conditions, एवम् अकुर्वतः तस्य दोषाः प्रवृद्धाः मांसशोणिते प्रविश्य शोकं जनयन्ति उपद्रवान् वा कांश्चित् तत्र उत्तरप्रतीकारः स्थिरामोक्षश्च. Now, if this is not followed, it will result in involvement of the soft tissues and it results in the complications. And in such conditions, Siramoksha is one of the options, along with the Shodhana is suggested as the treatment. Now, in this same chapter, later on, Sushruta refers to another word where Rasayaninam Drubaratva, Rasayani, the vessels becoming altered in the conditions of the prameha. We will come to that part, like the angiopathies or vasculopathies related to the diabetes is one of the important issue, and this is exactly what's suggested by the deeper involvement of the lesions. Like, so there you will have a involvement of the vascular conditions and all the other body tissues, including the fat and these proteinous muscle tissues, they would be affected, and that results in the next stage of the prameha. Now, if even at this condition, if it is not properly treated, evam akurvatah tasya shoko vruddho atimatram rujo vilaham apadyate tatra shastra pranidhanam muktam pranakriya upasevacha. Now, if at this stage it is not followed, it results in localized inflammatory conditions, which we call as the diabetic septic complications. So, you will have a diabetic vasculopathy, then you will have the diabetic septic complications, which could be presented as a diabetic ulcers, or the later on it can result in the further complication, and that's a stage where the patient, you need to treat the patient as you treat any other blood, any other wound, along with the surgical treatment if necessary, like either the drainage or maybe the amputation. एवम् अकुलतस्तस्य पूयो अभ्यन्तरम् अवधार्य उत्साङ्गं महन्तम् अवकाशं कृत्वा प्रवृद्धो भवति असाध्यः तस्मात् आदिते एव प्रमेहणम् उपकर्मेत. Even at this stage, if it is not followed properly, it can result in the more serious complications, irreversible complications, and gangrene like stages can occur. Now, that stage by stage description of the complications of Prameha, they are exactly what we discuss in the current science as the different complications of the diabetes mellitus. Now, in the diabetes mellitus, primarily it is if it is insulin resistance, particularly now this is true in type 2 diabetes. Now, most of these issues which are discussed in Sushruta are very much relevant in case of the type 2 diabetes conditions. So, initially it's the insulin resistance which could be triggered or which could be even managed with the exercise and diet. It's triggered due to the impairment of the food and exercise, and can be managed with the diet and exercise. That's the early stage, the Purarupa. If it is not treated properly, it can result in later complications, and the later complications could be resulting in a increased insulin secretion because of the resistance of the insulin, and this results in metabolic syndrome, the stage where the tissues are involved, and that results in the inflammation, thrombosis, or maybe the oxidative changes, and there will be endothelial dysfunction. So the vessels, blood vessels being involved, that is the stage as such. This, or it can result in the thicker vessels, either it could be the minor vessels which could be involved, or the major vessels which could be involved, which results in atherosclerosis. Now, once the atherosclerosis or minor vessels are injured, it can result in two sets of the complications, and the whole process would be like initially it's the insulin resistance which occurs, and there will be an impairment of the adipose tissues, the medomamsa being involved, which results in the alternation of the total metabolic effects and results in what we call as the metabolic syndrome. And as a result of the metabolic syndrome, you will have the different sets of changes which occur. Either it could be endothelial dysfunction. We will just discuss these somewhat in slightly more detail later as we go ahead. Then there will be a systemic inflammation. That's the situation where all the dhatus are involved, and that results in either thrombogenic conditions where there could be abnormal vascular movement, and there also would be hormonal dysfunctions, and the vascular tone would be affected. Rasayana Daurbalya would occur, and that results in involvement of the different organs of the body. When the same changes occur in the cardiac microcirculation, it can result in coronary artery complications, or it can produce a peripheral arterial disorders or cerebrovascular complications where the minor vessels, capillaries, or maybe the venules are involved. When the major vessels are involved, where there is a bigger thrombosis, macro vessels, when the larger vessels are involved, that produces same. When the minor vessels are involved, it can result in hepatic pathology, nephropathy, retinopathy, as well as peripheral neuropathy. So that's what we categorize as the micro and macrovascular complications of the diabetic vasculopathy. So that's the whole sequence of the events which occur as a complication of the diabetes. And this is exactly the mirror image of what Sushruta has said about the different stages. The only issue is whether these stages can be reversed by the said protocol like the Shodhana and the Raktamokshana or not, and this needs to be established in a manner which would be acceptable to the present society now. Of course, definitely yes, if we try that, it can be prevented and it's possible. Now, what we mean by those endothelial dysfunction and so on, how the changes occur. See, in the normal situation, the endothelium of the blood vessels, particularly vascular endothelium, has the property of facilitating the movement of the blood without coagulation. It's a non-sticky surface, smooth surface, and the vessels are expansible. The vessels can either expand or relax so that the blood pressure is maintained at an optimum level and the tissue perfusion occurs normal. In the patients who have the diabetes and due to the insulin resistance, the endothelial cells would lose their property of maintaining this smooth function as well as the vascularity of the or elasticity of the vessels tend to get involved. Now, once the endothelial surface becomes somewhat rough and its smooth character, non-metting character is lost, it results in a possibility of clotting within the vessels, or maybe there will be a degeneration result in atherosclerosis. Atherosclerosis is there will be initially atherosис, the endothelial vessel tissues will become degenerated and becomes a cheese-like degenerated substance, and that's why it's called as atherosис. And when it results in involvement of the vascular, the elastic structures, then it's atherosclerosis. That results in, once that atherosclerosis occurs, the vessels become rigid and they are not able to expand to fully. In it, they tend to become less elastic, and that results in hypertension. The blood pressure increases, and the blood pressure increase will produce a load on the heart, and that can result in a cardiovascular disorder. Cardiovascular disorder also can be directly related to the atherosclerosis. So, the sequence of the events would occur, and it's a sort of chain reaction which continues to affect one to the other. The endothelial vasomotor changes, now they are now identifiable. Sushruta has not mentioned about the methods of how to identify them, but now they are identified by different tests. Many a times we may not do the tests properly in the routine clinical practice. Generally, we may not do the tests regularly, but whenever there is a need, they can be tested, or whenever you need to go for some protocols, research protocol studies, these tests could be done easily. And among the tests done are mainly the important tests, and relatively simple tests would be the peripheral circulation, where the brachial artery pressure can be managed, or venous impedance or plethysmography, which are strain gauge plethysmography. I suggest like how it can be done simply in the routine clinical conditions also it can be done. So that's the test which could be done. Whereas for the coronary circulation, the investigations will be a bit more invasive. We need angiography, which may not be possible in routine clinical conditions, or it could be coronary Doppler or Doppler echocardiography, or still positron emission tomography also may be done. These are done in very specialized centers to identify the patients of the rasayani dorbhaja. Endothelial vasomotor changes can be identified at an early stage, whereas in the routine clinical conditions at the GP level, where we do the conditions, where we may not go for these sophisticated investigations regularly, it's mainly the circulatory pressure, blood pressure, and the lipid profile would be the other issues, or maybe at the most when you may have a strain gauge venous impedance plethysmography. That plethysmography is simply you have to have 2 cups of blood pressure monitor. The 1 cup which is kept at the proximal side is kept at 40 millimeters of mercury, so that the venous circulation is impeded. The distal one is kept at a level higher than that of the arterial systolic pressure, something around 150 millimeters of mercury. Now, once you do this, if there is a normal circulation, this area will be bulged, because arterial circulation is blocked towards the distal side, and the proximal side, the venous circulation is blocked. There will be stagnation of the blood, and this results in a raise in the pressure here, or raise in the total volume of blood collected over here. That results in minor changes in the size of circumference of the forearm, which can be recorded, and this can be compared to the normal, and then the extent of that circulatory abnormality can be noted without any invasion. The whole procedure has to be done within 5 minutes. So it cannot be just arterial circulation cannot be impeded beyond 5 minutes. So it has to be done as such. And then you have the calculated tables where you can get the normal value as well as the abnormal value. And this is one of the simple investigations which could be done. Or now another set of the investigations which are now becoming popular are biomarkers of atherosclerotic vascular disorders at different stages. The atherosclerotic pathology can produce different complications. Among them, the common investigation which can be useful in the routine clinical practice and relatively simple, which is available, is CRP, C-reactive protein study, which can suggest about the inflammatory process which has set in. In a diabetic patient, if the CRP is higher, then you have a high chance of vascular complications, atherosclerotic complications, and you have to be careful. The other investigations like assessment of fibrinogen or lipoprotein, etc. And then, of course, another very important investigation is uric acid. Uric acid level also is a sign of inflammatory pathology, which I do regularly in routine clinical practice in almost in every patient, which can give you a guideline. And I prefer CRP and uric acid as the investigations because they are relatively simple and cheaper. The other investigations like IL-6, fibrinogen, or tumor necrosis factor, these may not be so easily available in our setup, so we may not do it routinely in our setup, but in a sophisticated setup, or if we are planning for some research protocol, these also could be included. The atherosclerotic plaque, if in the advanced stages, there could be a complication of the atherosclerosis and atherosclerotic plaque, which can be even predicted earlier, before it has occurred, by mRNA studies, or of course CRP also is a guideline. And if there is a clot formation, that also can be predicted, or neurohumoral activation, which is the next stage of atherosclerosis, or complications of atherosclerosis, also can be predicted now. So these tests are available now, though they are not so freely available, but one of the common investigations which we can do are CRP and uric acid in a patient with diabetes mellitus, which can predict about the complications. Now, the type of the complications which can occur could be, as I told earlier, it's the same, it's a somewhat repetition, but I am just stressing upon, because these are important clinically. A patient who has cardiac complications, these coronary vascular disorders, which is a macrovascular complication, there the patient symptoms could be angina, shortness of breath, tachycardia, or ST elevated or non-ST elevated MI like signs seen in ECG. And of course, diabetes mellitus with the atherosclerotic buildup and hypertension, these are the major risk factors. And of course, the these diagnostic tools which are used are lipid screening, the lipid profile, C-reactive protein, lipoprotein particles are these are the tests which could be done routinely. So the point is, every patient of diabetes mellitus, you need to be aware of these possible complications and have to screen for these complications. Peripheral artery disorder, that the symptoms could be cramping, numbness, or discoloration of the distal limb, weak pulse as such, which can be easily done in the routine condition. Ischemic resting pain. Causes are tobacco usage aggravates this problem, and ankle brachial index or digital subtraction angiography could be the more sophisticated investigations to rule out that. Important is the microvascular changes cannot be made out with the Doppler study, whereas only the macrovascular changes can be made out with the Doppler study. So only those macrovascular changes, Doppler study would be useful. If the Doppler study is normal, that doesn't mean that the patient's circulation is normal. So the other microvascular complications which cannot be identified with the Doppler study are nephropathy, where the patient would have microalbuminuria, oliguria, or anuria, later complications. Of course, in the next chapter where we will discuss about the Prameha, we will discuss more about these issues somewhat in detail. The risks are again hypertension, patients who have hypertension and type 2 diabetes. The other evidences, confirmation can be done by albumin evaluation or glomerular filtration rate or albumin creatinine ratio, and in advanced stages renal biopsy also could be done. The next is about the liver disorder, non-alcoholic fatty liver disorder. Of course, we have discussed that in detail in some other context in earlier sessions, like, which is also a microvascular complication where the clinical symptoms could be jaundice, ascites, gynecomastia, etc. And the type 2 diabetes, it's more common in such conditions. Of course, the screening test would be liver enzymes and liver imaging. Another quite significant is retinopathy. Retinopathy now has become very common in patients of diabetes mellitus, and it's also considered as a primary diagnostic criteria, where the changes in the retina can be made out with the fundoscopy, where the patient may have the dots in the retina seen on fundoscope as such. And the confirmation of the diagnosis done by fluorescein angiography or simple this fundoscopy also is done as such. Cerebrovascular events are carotid artery diseases, like where there will be cerebrovascular accidents, where the initial symptoms will be dizziness, dysarthria, which we have seen many patients in the ward. Many of the patients with the TBA, they have these as complications of the diabetes. And the investigations could be ultrasound, CT, angiogram, MRI, etc., which we do routinely. Then peripheral neuropathy, the clinical symptom could be the burning sensation, tingling sensation, impaired sensory sensations, sensory loss to touch, vibration or temperature, or it could be local severe mononeuropathy where one muscle could be having affected with pain or atrophy, or there could be autonomic neuropathy where the patient may have what we call as a metabolic syndromes. The confirmation could be the skin examination, circulation analysis, or maybe the protective sensation examination, pinprick test, or the reflex test, which are done routinely, or electromyography could be the other investigation. Now, once we have made these investigations and graded the complications, the treatment question comes in. In the present day situation, the treatment guideline limits only to a rigid maintaining of the glucose level and regular exercise, nothing beyond that. Then once the patient has developed the complications, then there will be a specific treatment for the specific organ pathology, like a renal involvement, you will have to have renal protective regime, cardiac involvement, cardiac protective regime, and so on. So otherwise, there is no specific protocol of treating that. Whereas Sushruta mentions about certain of these protocols which can prevent these complications, or maybe to a great extent cure these complications also at some stages as such. And among them, one is Bhallataka Yoga. Bhallataka, Bilwa, Bilwambu, Pippali Mula, Udakirya, Varshapu, Punarnava, Chitraka, Shati, Snuhi, Varunaka, Pushkara, Danti, Pathya, Dashapalonmiraha, Yavakola Kulathamsha, Prastikan, Saliladrode Nishpatya, Chaturbhaga, Vashishya, Utarya, Vacha, Trivurta, Kampilaka, Bhangi, Nichula, Shunti, Gatapipali, Vidanga, Rodra Shri Shanam, Bhagi, Ardhabalike, Gritapatsam Vipache, Meha Shwayatu Kusta Gulma, Udara, Arshat, Liha, Vidrati Pidaka, Nashanam Namna, Dhanvantaram, Gritam, Dhanvantara, Grita is one. And preparation of the Dhanvantara Grita, you will have to use these Ballataka, etc. Along with the Yava Kola Kulatha, one prasta, and this has to be prepared into a kwatha. 1/4 has to be reduced to 1/4, and Grita has to be added, and Grita Paka has to be done, which could be used in Shwayatu, Kusta, Gulma, Udara, etc. Then Durviratyahi Madhumeha Bhavanti, Medo Apivyapta Shariratvat, Tasmat, Tikshnam Etasham Shodham Kurvita. Madhumeha, diabetic patients are difficult to be treated with Virechana. There are two issues. One, they are because of the metabolic syndrome, many of such drugs which can produce Virechana may produce effect unpredictable. Either there could be very critically serious diarrhea-like complications or dehydration-like complications can occur. Some of the patients may not be responding to these Virechana dravyas. This happens quite frequently when we give Virechana to a diabetic patient. Or even after the procedure, complications also could be more. And hence, Sushruta suggests you have to have a Tikshna Virechana dravya in such patients. Then Pidaka Piditaha Sopadruvaha Sarveva Prameha Mutradi Madhurye Madhugandha Samanyat Paribhashikim Madhumeha Kyam Labante Nate Etan Katanchitali Swedayet Medo Bhutvat Etesham Shirite Deha Swedena. Now, all the Prameha conditions, when they develop into the complications, and the complications are called as Madhumeha, diabetic complications, where there could be either Pidaka. When I say Pidaka, it's not only the diabetic carbuncle or septic complications, it could be prior to that, the vascular complications also, or when there is a systemic involvement, that could be considered as Madhumeha. Rather, the other way, a better term would be Madhumeha could be equated to the chronic renal disorder, nephropathic. End stage renal failure could be the complications. So, when Sushruta deals with the next chapter where there would be Madhumeha chikitsa, that part we will discuss, and from my point of view, I would always consider Madhumeha as equivalent to the renal disorders. Renal either hypofunction or chronic kidney disease or end stage renal failure, all of them could be considered as Madhumeha, whereas in our routine language, the diabetes is considered as a Madhumeha. Even Sushruta's period, that kind of an issue was there, and hence Sushruta used Paribhashiki Madhumeha Kyam Labhate. due to the paribhasha, the colloquial language, many of the people may consider this stage as a madhumeha. But once it has resulted in that renal involvement, or where there is a change in the electrolyte constitution of the body, or when there is a vascular abnormality, in such condition, nachetan katanchidapi swedayet medo bhutva detesham vishiyate deha svedena. Svedana is contraindicated, and if the svedana is contraindicated, naturally the shodhana also become contraindicated or difficult. So if you have to give virechana or the vamana, Svedana has to be either carefully done or should be avoided as far as possible. The woman and the virechana is always better suitable in the early stages and for prevention than really the cure of the complications. If a patient of diabetes has resulted in a renal pathology, renal involvement, I never give virechana or vamana. I never give virechana and vamana in such patients, because that results in more serious complications as I have observed. So I limit virechana only to the early stages of diabetes where there is no definite evidence of vascular involvement or renal involvement, particularly renal involvement. And the reason given by Sushila is rasayani nanti daurbalya. The rasayani daurbalya, the vascular manifestations, endothelial changes which we have discussed, they were known to Sushila much earlier than what the current science says. रसायनीनां दौर्बल्यात् न ऊर्ध्वम् उत्तिष्ठन्ति प्रमेहिनां दोषाः ततः मधुमेहिनाम् अधक्काये पिडकाः प्रादुर्भवन्ति. Now, because of these vascular issues, the movement of the blood towards the superior side would be lesser. So gravitational force would be acting upon the circulation. The capacities to cope up with the gravitational force of the body would be lesser, and that's why there is a tendency for the stasis of the blood in the lower limb, and the incidence of complications like diabetic complications like ulcers or gangrenes, they tend to occur more frequently in the lower limbs. Now, diabetic ulcers, they tend to occur due to the rasayani daurbalya. And in the present day situation, the diabetic ulcers are a very commonly seen conditions, and there could be different types of the classification and the stages. The stages, the common mode of assessing the stages of diabetic ulcers are the stage of cellulitis or deep skin soft tissue infections. Now, skin and soft tissue infections are extended cellulitis stage. These are the two stages which Sushruta has considered as sadhya, where the Tokmamsa sthayi, it's limited to Tokmamsa, and then it can be treated if conditions are, if the patient is having physical strength, and if it is resulting in a suppurative complications, pyogenic complications. But if it is a gangrenous complications, then it may not be possible to treat. That's exactly what Sushruta says, Kshiprabhakaha. Kshiprabhaka are sadhya, whereas the others are not so easily curable. Then the next stage is which can result in osteomyelitis, and the acute or chronic osteomyelitis could be the presentations. Acute osteomyelitis, where the patient may have acute septic conditions, where the patient may have high degree of fever and local pain. Chronic osteomyelitis, where the patient would have pus discharge and sinuses. Majority of the patients whom we see in our clinical practice, they directly enter into chronic osteomyelitis stage. The acute osteomyelitis stage is generally for a very short duration, which we may miss in majority of the conditions. Of course, you will have a good number of patients who have this also. Then you have the irreversible changes where there is a total vascular obstruction and gangrene. These are considered as the stages of the diabetic complications. Now, the clinical features, signs are, of course, or my slides sequence is slightly changed. The cellulitis stages, once the patient of diabetes has these clinical symptoms, where there is a tender erythematous non-raised skin lesions are present, and sometimes it could be the lymphangitis which could be seen as such. They are the signs of cellulitis, and most of these cellulitis conditions are due to gram-positive organism like streptococcal or staphylococcal aureus, and there could be some bullae bug as also can occur in such conditions. Then the cellulitis may result in deep skin and maybe soft tissue infections. Where the patient may have painful induration of the soft tissues in the extremity. There could be a wound discharge, either not much of a discharge, but the whole area is inflamed. Now, like the patient whom we have now in the general ward, that Nagabhushan, the patient who is there in the ward now. That's exactly the evidence of the skin and soft tissue infections, extended cellulitis stage as such. And there the organisms could be any anaerobes also could be presented in that condition, not only the aerobes. That your selection of the antibiotics has to be more broad spectrum and should be effective for the anaerobic organism. The extreme pain and tenderness may indicate compartment syndrome. That's when there is a accumulation of pus there deep side, and that pus itself is producing the compression upon the nerves. There could be severe pain and which needs an urgent drainage. If there is not much of a compartment compression, you may not go for an immediate drainage. The tissues may not be very tense as such, and discharge is often foul. Whereas in acute osteomyelitis conditions, the next stage where the patient may have an acute osteomyelitis conditions, there could be having severe pain at the area unless the patient has a peripheral neuropathy. The fever and regional retinopathy are not much as in case of acute osteomyelitis produced otherwise. Chronic osteomyelitis, the patient would never have high temperature, usually less than 102. Discharge is very foul and lymphangitis may not be observed like, and pain may not be severe or may be very mild pain as such. And deep penetrating ulcers and deep sinus tracts could be seen. X-ray will show the evidences of the changes in the cortex of the bone or even total erosion. So it starts with the cortical changes and then the total erosion of the bone seen in the X-rays. So in a chronic osteomyelitis, X-rays can be useful, and the medial malleoli shins or heels are not usually sites of the involvement. They are involved only in the foot pressure, like distal most area are the more common areas as such. Plantar surface of the foot and the toes are the usually located areas. Then of course the gangrene where you will have the typical dead tissues, vascular response will be totally absent as such, and either it could be a localized dry gangrene or it could be a wet gangrene depending upon the other presence of the complications, where you will have changes in the skin color and swelling, blisters and severe pain, foul smelling discharge, and the skin color also is common. Either it could be either cold or at times it could be hot to touch at that area. The most important is the vascular signs like the capillary reflux or venous refilling would be absent as such. Peripheral pulses also would be absent in conditions. Now diabetic ulcers are graded under different classification, but the most common classification and most frequent is classification is Wagner's classification. In the Wagner's classification of diabetic ulcers, which helps in predicting about the approach to the treatment, are grade 0 is where there is no ulcer but the patient has a high risk where sensation is altered or patients have diabetic neuropathy symptoms. Grade 1 is where the ulcer is very superficial. Grade 2 is deep ulcer but no involvement of the bones. Grade 3 is abscess with the bone involvement as shown in X-ray. Grade 4 localized gangrene, and grade 5 is extensive gangrene. This is the most popular method of grading the diabetic ulcers. Classification of the ulcers have lots of other methods. Of course, the other methods which are often used in many textbooks are either University of Texas classification or PD's classification or Sinbad classification. These are not very routine clinical practice, but still they could be useful in some research activity. If we are aiming at research activity and particularly we are targeting about the sensation, the neurological conditions is a PD's one which is commonly involved, whereas Sinbad is mainly for the vascular complications which are involved as such. Or one more of the type of the classification which is again useful in predicting the outcome would be the Wi-Fi classification or wound ischemia and foot infection classification, where you assess the wound, the ischemic issue and the infective issue separately and grade them separately, and this would be very practical as such. This wound, you have almost a similar issue like 0 no ulcer, small ulcer where there is no gangrene, 2 is deep ulcers, extensive ulcer is grade 3 or gangrene. The ischemia is assessed by toe pressure with the oxygen concentration. It is something like the same pulse oximeter which we use, but the cable that has to be a part of the toe, you need to have an extension cable. The oximeter is almost same as such, with which the oxygen level in the toes could be assessed, and based upon that the toe pressure or the vascular pressure also can measure with that the toe pressure monitor. It's something like the oximeter, only pulse oximeter only for toes, which is available in the market. Then the infected conditions based upon the evidence of the infections: mild infection where the cellulitis is less than 2 centimeter, moderate is when there is more than 2 centimeter cellulitis, severe is where the patient has a septic complications. Now these gradings would be deciding about like how to approach the treatment. If the grading is higher, then the patient needs more energetic treatment. Only the early stages can be treated with only allergic management. So from my clinical point of view, I use these gradings at least to a certain extent to decide like whether the patient needs some other contemporary treatment or not, whether the patient needs amputation or not. These can be predicted based upon these gradings as such, and hence these gradings are important. Management as such, in general, patients who come with the cellulitis, we can manage with our treatment, ayurvedic treatment, plus occasionally antibiotics. Antibiotics are generally prescribed because the course is rapid. Even the deep conditions also, extended cellulitis conditions are also curable, but that could be debridement occasionally needed. That's, you may have to remove the tissues, dead tissues may have to be removed. At times it could be by blunt dissection, as we do with only the cotton and these hydrogen peroxide like solutions. You may remove the simple debridement. Patients who have acute or chronic osteomyelitis, surgical debridement is necessary, and antimicrobial therapy is absolutely essential. And a conservative management of our ayurvedic treatment may not be sufficient as such. In the gangrene, of course, amputation is mandatory. And the usual treatment which I prescribe would be Asanadi Kashaya, Triphalagubulu Gandhaka Rasayana. Along with that, whenever there is a need, the anti-diabetic drugs to maintain the diabetes, as well as antibiotics may be necessary based upon the presentation as such. The general guidelines for the diabetic food, the popular guideline for the diabetic food now is not to go for an energetic treatment, an energetic amputation early. Wait and watch is the current method, whereas earlier people used to go for jump for the amputation earlier. So the best option, whether you treat with Ayurvedic treatment or not, the best option is a wait and watch, as far as possible, be conservative, reduce the tissue damage. That's the one protocol now standard. And the protocol is, if a patient has a diabetic ulcer and there is not much of a gangrene, then assess these, grade the patients, and if the patient has a low Wi-Fi scoring, as I said earlier, then you have to, maybe in the current technology, where you will have another option of revascularization where vascular surgeries could be done, could be the other option, which we may not. Whereas Manjishadi Ksharamastri can be a good alternative to the revascularization from our point of view. Then if the patient has a very pronounced gangrene changes, then only you may have to go for amputation. This is the current trend in the approach to the treatment. Conservative trend is preferred as such. Now, the line of treatment suggested by Sushruta also is on the same lines to a great extent. The approach is apakvanam to pidakanam shopavat pratikaraha. Like in the cellulitis conditions where there is apakva pidaka, it is a shopavat pratikaraha. Pakvanam ranavata. Once it has resulted in a pakva rana, where there is opening wound, then it has to be the rana, as the same rana chikitsa protocol has to follow. Tailam to ranaropanam eva adau kurvita. Unlike other conditions where you have to wait for the Shuddha Vrana Lakshana and then use the Ropana, Sushruta suggests in a diabetic patients, you may use the Ropana Taila in the beginning. Aragbodadi Kashaya Mutsadanarte. Aragbodadi Kashaya is suggested for the Utsadana. Shalasaradi Kashayam Parishetane. Pipalyad Kashayam Panabhojaneshu. Pata Chitraka Shandeshtak Shudra Brihati Sariva Somalka Saptabrana Aragboda Kutuja Mulaturnani Mudimishtrani Prashniyata. For the different Kashaya, we generally prefer single Triphala Kashaya, whereas Sushruta has suggested that different options like Arabhya Kashaya for Utsadana, that's to remove the debris, and Shalasarad Kashaya for just cleaning, and for internal administration, Pipadad Kashaya, Pata, etc. ಶಾಲಸಾರಾದಿವರ್ಗಕಷಾಯಂ ಚತುರ್ಭಾಗವಿಶಿಷ್ಟಂ ಅವತಾರ್ಯ ಪರಿಸ್ರಾವ್ಯ ಪುನಃ ಉಪನೀಯ ಸಾಧಯೇತ್ ಸಿದ್ಧ್ಯತಿ ಚ ಆಮಲಕ ರೌದ್ರ ಪ್ರಿಯಂಗು ದಂತಿ ಕೃಷ್ಣ ಅಯಃ ತಾಮ್ರಚೂರ್ಣಾನಿ ಅವಪೇತ್ ಏತದ್ ಅನುಪದಗ್ಧಂ ದೇಹೀಭೂತಂ ಅವತಾರ್ಯ ಅನುಗುಪ್ತಂ ನಿದಧ್ಯಾತ್ ತಥೋ ಯಥೋ ಯೋಗಂ ಉಪಯುಜ್ಯೇತ ಏಷ ಲೇಹ ಸರ್ವಮೇಹಾನಂ ಭಕ್ತ. Another meha hara leha is suggested where the use of krishnaya, that iron and tamra churna also is suggested in the leha form. So one of the example of metallic substances used in sushruta which is compared lesser, whereas after rasa shastra we have plenty of such substances now available. त्रिफला चित्रक कटुक विडंग मुस्तानां नवभागाः तावन्तेव कृष्ण अयश्चूर्णस्य तत्सर्वम् एकघ्यं कृत्वा यथा योगं मात्रां सर्पिर्मधुभ्यां संसृज्य उपयुज्येत एतन्नवायसम् एतेन जाठर्यं न भवति सन्नो अग्निः आप्यायते दुर्नाम शोफ पाण्डुकुष्ठरोग अविपाककाशश्वासप्रमेहाश्च न भवन्ति. Namayasa churna, now in the market it's available in the same name, Namayasa churna, and it's prepared with the triphala etc. along with the loha basma. Now the loha basma is added, whereas Sushra has suggested ayas churna. And these are used in prevention of the diabetes as well as hemorrhoids or otherwise shofa, pandu etc. Then another yoga is शालसारादि निर्युहे चतुर्थांशावशेषिते परिश्रुते तदशीते मधुम् अक्षिकम् आवपेत फाण्डि भावमापन्नं गुडं शोधितमेव च श्लक्ष्णपिष्टानि चूर्णानि पिपर्यादिगणस्य च एकघ्यम् आवपेत् कुम्भे संस्कृते घृतभाविते पिप्परीचूर्णमधुभिः प्रलिप्ते अन्तःशुचौ दृढे श्लक्ष्णानि तीक्ष्णोहस्य तत्र पत्राणि बुद्धिमान् खदिर अङ्गारतत्तानि भविष्यत् सन्निपातयेत् सुपिधानं तं कृत्वा यवपल्लेर्धापयेत् मासान् स्त्रीन् चतुरो वापि यावद् आलोह संक्षयात् ततो जातरसन्तं तु प्रातः प्रातर्यथा बलं निषेवेत यथा योगम् आहारं चास्य कल्पयेत् काश्यकृत् बलिनां एषः सन्नस्य अग्नेः प्रसादकः शोपनुत् गुल्महृत् कुष्ठमेह पाण्ड्वामयापहः प्रीहोदरहरः शीघ्रं विषमज्वरनाशनः अभिष्यन्दापहरणः लोहारिष्टः महागुणः. Another of the loharishta, loha yoga, where the arishta is done, and again the loha, the iron pieces, are kept in the kashaya after heating them. Kadirangara tuttani bhavishyat snipateta. After heating in kadirangara, they are dipped in kashaya. Till they get to dissolved, they are stored as fermented. That a fermentation product is done with loha, that's called as loharishta. यदा प्रमेहनो यदा मूत्रम् अपिच्छिलम् अनाविलं विषदं तिक्तकटुकं तदा आरोग्यं प्रत्यक्षते. To confirm whether the patient is relieved of prameha or not, Sushruta was depending upon only the examination of the urine, whereas now you have plenty of sequence of investigations which can predict about the outcome, the status of the patient, as well as the possible complications. So all these investigations are relevant. Now, though Sushruta has limited to the evidences seen in the urine, where the urine is clinically normal, that's a sign of relief of the prameha according to Sushruta. With this, the Prameha pidaka chikitsa iti Sushruta samhitayam chikitsa sthane Prameha pidaka chikitsa nama dvadashodhyayah. With that we will conclude today. If there are any questions, we will try to answer. There are many questions. Fresh grita and oil for daily can be given in a high lipid profile and atherosclerosis. See, grita and oil given daily is something different, and grita or oil given for the preparation of shodhana, they are different. Grita and oil given for the shodhana would always be in high quantities, prabhuta matra, and they have a washing effect. They reduce the lipid content. Whereas consumption of the grita daily would add to the lipid content. So I would not suggest consumption of any such grita or the oil in excess, in larger quantities regularly. Maybe occasionally in small quantities, fine. Then what complications are seen in virechana given in diabetes with renal impairment? Aggravation of the renal pathology. Creatinine levels often tend to increase many a times after the virechana. I have seen that in many patients there could be a sudden worsening of the chronic kidney diseases. Then asanadi can be given in all stages of diabetic patients. There is no contraindication. The only issue is the asanadi kvata has to be prepared afresh. A stored asanadi kvata with preservatives I don't prefer. And some of the patients may not like the taste of the asanadi kvata, so they may not like it, that's all. But there is no contraindication for the asanadi. That's about the questions, like, right? Okay. With this, we'll wind up. Okay.
Thank you, sir.